All righty, I'm going to begin again here for a second and talk about CFE/ME. And I thought the topic would have come up earlier today, but apparently it did not. Another highlight of the IACFS meeting that we had in January was that many researchers got together and voted to start calling chronic fatigue syndrome ME, which we have dubbed myalgic encephalopathy. You may know that ME is a term that's been used in Europe for years, and in Europe and in other English-speaking countries it refers to myalgic encephalomyelitis. For years we've been searching for a term that would better describe what patients feel and experience, and just didn't feel that chronic fatigue was the here-all and the end-all. And so we've tried to come up with a variety of names, and there's never been consensus until January when a large group of professionals got together and we voted to start calling it ME, or myalgic encephalopathy. /ME, there you go, chronic fatigue syndrome /ME. The reason that we keep the chronic fatigue syndrome in there, of course, is that there's already 20, 30 years of data that's in data banks, that's in libraries, that's in computers and so forth, where it's called chronic fatigue syndrome. You just can't wipe out chronic fatigue syndrome. And so for the time being, at least, we're going to be using CFS/ME or ME/CFS to refer to the illness that we're talking about mostly today. So that's where the ME part comes to. Now, what Cindy Bateman asked me to do was to summarize a unifying theory, just explain what is it that causes chronic fatigue syndrome and how does it happen. And I'm going to try my best to do that. But it's a big topic, and if we have any time left afterwards, we'll talk about the gubernatorial or the presidential debates, maybe handle peace in the world, whatever we have time for afterwards. But I'm going to give it a try, and interestingly, I listened to part of Nancy's talk, and I think it's going to amplify a little bit of what you learned from her. So I hope you get something out of it. Now, let me start by saying that prior to the 1980s, if you went to the doctor and you complained about the symptoms of chronic fatigue syndrome, the doctor would conclude that you were either a hypochondriac or you were crazy. And in either case, you needed a psychiatrist, you didn't need him, okay? Things changed, though, in the early 1980s. There was a very unusual phenomenon between 1983 and 1985, and that was that there were 3 large outbreaks of chronic fatigue syndrome. One in Lake Tahoe, one in Rochester, New York, and one in Raleigh, New York, where I was practicing. And what we learned from these epidemics, is that the patients were all singing the same tune. They may have been whistling, they may have been singing, they may have been humming, they may have had a different orchestra behind it, but it was always the same tune, just a variation. And those symptoms were typically flu-like symptoms, like the muscle aches and pains, the joint pains, the sore throat, the headache, the cognitive complaints, the fatigue, of course. And we all know that it's more than fatigue. It's more than just tiredness. It's a total lack of energy. It's a lack of stamina. And then the sleep disorder, specifically the non-restorative sleep, is what we saw. So I like to refer to this as the pain, the brain, the energy drain, and oh, I wish I could sleep again. That's how I remember the 4 major symptoms of chronic fatigue syndrome. In addition, we soon learned that many of our patients were susceptible to what we called overlap syndromes. That is, patients with CFS/ME and fibromyalgia were much more susceptible to things like an overactive bladder, irritable bowel syndrome, celiac-like illness. We found soon that there was suppression of the HPA axis, and fibromyalgia was very common with chronic fatigue syndrome patients. Hypersensitivities, chemical sensitivity, and sleep disorders. So we learned a lot about the illness. The problem was, how can you go about explaining something that's that complex? Well, the first thing we wanted to look at is what seems to trigger off chronic fatigue syndrome. And I'm only aware of two good papers that discuss precipitating factors or triggers in chronic fatigue syndrome, or CFS-ME. The first one was published in 1997 by Irving Sallet, who's an infectious disease specialist in Canada. And in studying patients in his practice, he found that about 85% of the patients developed their illnesses acutely, and about 15% had a gradual or an insidious onset to it. And those people who developed it acutely had sort of a pattern that he saw. 72% of them seemed to be triggered by a bacterial or a viral infection. So the large majority were triggered by an infectious-like illness, and the rest trauma. And interestingly, this is not major trauma. We're talking fender benders. We're talking slipping on the floor and cracking your head, or and even a trauma like childbirth or surgery was enough to trigger off some of the cases. The second paper was published in 2002 by De Becker and her colleagues in Belgium. And here they found a similar sort of pattern. As you can see, the infectious causes were attributed to about 78 or 80% of cases, just as they were with Sallet. A small amount to stress, a small amount to accidents. They noticed some very interesting triggers too. Insect bites, vaccinations. And you can see that in their particular study, about 37% of the cases, they never could figure out what triggered it off. Now, for those of you who are quick enough to add up that right-hand column, it adds up to more than 100 because some patients had more than one trigger. So there. Since then, we've identified some other triggers too. Pesticides, for example, the organophosphates like malathion have been known to trigger chronic fatigue syndrome, ME. And carbamates, probably the most common carbamate that you would know is the pesticide 7 that we use, treat our pets, treat our households to keep pests out of the household. Heavy metals, particularly mercury, have been known to trigger it off. And more recently, we're seeing that toxins can do it too, like isocyanates that are used in varnishes and shellacs and paints. Formaldehyde used in the building industry, particularly trailers and double wides, that sort of thing. And I guess more recently, even Pfiesteria has been involved, which is a bacteria. We see it in North Carolina. We see it in Maryland. It's a bacteria that causes a CFS-like illness that comes from fish, actually. But this is the important point that I was trying to make. In both the Sallet paper and in the paper by De Becker, they noted that almost 100% of the cases were preceded by serious stress. It seems that stress may be one of the precipitants or one of the things that makes people susceptible to CFS/ME. So what do we know about this crazy illness? How can we explain all of these triggers and all of these symptoms in one disease? Well, I think Nancy elucidated earlier the number of immune abnormalities. That was one of the first things that we know. Because it appeared like an infectious illness, we really looked very early for immune-type problems. Why did people get infections that just didn't go away? And then secondly, we started noticing all the central nervous system problems, like decreased cerebral blood flow and decreases in neurotransmitters like epinephrine or norepinephrine and dopamine and serotonin. We found neural sensitization and increased NMDA receptors and things like that. By 1992, Democrat had elucidated that the HPA axis was suppressed, which explained a lot of symptoms, and I think you talked earlier about the HPA axis. And in 1995, Peter Rowe and Bohologa and others at Johns Hopkins were able to tie orthostatic intolerance and neurally mediated hypotension in particular to chronic fatigue syndrome. And since then, we've learned that the autonomic nervous system is involved. We know that cytokines can cause symptoms because cytokines are now treating diseases like hepatitis C, for example. And when you inject cytokines, they cause the same kind of symptoms that we see in chronic fatigue syndrome. And we know that there are biochemical and metabolic abnormalities, and I think you learned earlier from Dr. Vernon that many of the genetic studies that we're seeing now are confirming some of these clinical impressions that we originally had. So what I'm going to try to do is pull it together a little bit, and I would like to say that this is all my work, but it's not. This is the work of many, many individuals, and I would particularly like to start by thanking Kenny DeMarie and Bob Sadolnik, who are able to unravel what we call 2,5-OAS system and RNase L problems. Patrick Engelbein, who has helped us to understand what channelopathies are. Martin Paul, who has made us aware of the nitric oxide and peroxynitrate problem, and Grace Ziem and Iris Bell, who have helped us to understand neural sensitization and multiple chemical sensitivity. But there are many, many others. Now, the second thing I'd like to say is that this is very complicated, and it's a late afternoon, so don't get too uptight. I would just like you to sit back and follow with me here, and then you have all of the printouts in what was given to you today. You can go back and study it a little bit later, but see if you can just get the general idea of how this works. It's my recollection that it was Jay Levy back in the early 1980s, an early AIDS researcher, who first suggested that chronic fatigue syndrome may be due to a hit-and-run phenomenon. In other words, some sort of an infectious agent or some sort of an agent would hit, would cause damage, and then would leave. The agent's gone, you can't find the agent, but the damage is still there. And that led next to what we called the Agent X theory that was very commonly touted and still used today, but very commonly touted in the early 1980s. And this states that there's an agent, whether it be infectious or chemical or whatever, that causes immune suppression. And when the immune system is suppressed, then it allows for the escape of latent organisms. And latent organisms are things like the herpes viruses that once you acquire them as a child, they stay in your body forever. But the immune system contains them and keeps them under control. And so when the immune system weakens, then these viruses can escape. And a good example of that would be chickenpox that you acquire as a child. If you get weakened as a mature adult, then the chickenpox can come back out again, not as chickenpox, but as shingles. Right, exactly. So that's a good example. So when these organisms are reactivated by a weakened immune system, then you get all of the symptoms of the original infection. And not only that, but it also causes immune activation. In other words, the immune system is not foolish, and it recognizes that these have escaped, and so the immune system fights them off. Now, some people ask me, how is it possible that you have an immune system that's overactive there and underactive there at the same time? And the only explanation that I can get, well, I'm going to show you an explanation in a moment, but the example that I use is like an automobile where the car is running but the clutch is in. So the engine is running fast, but the car's not getting anywhere because the clutch is not set in. So let me talk about the infectious part here and the immune part here, and again, with apologies to Nancy, who's gone over some of this already. There are a number of things, particularly viruses or toxic chemicals or ionizing radiation, that can affect a macrophage. And macrophages are amoeba-like cells that circulate in the bloodstream, and they also circulate underneath the skin, looking for invaders, looking for foreign entrants into the body. And when the macrophage contacts something foreign, it sets off an alarm that we call interleukin-1. That's a cytokine or a lymphokine called interleukin-1, which then contacts lymphocytes that are circulating and does two things. It stimulates the production of other cytokines, like interferon and TFN-alpha, or TNF-alpha, and it also stimulates interleukin-2. another alarm system. Now, when interleukin-2, another cytokine, contacts other lymphocytes, it activates the lymphocytes, and little markers appear on the surface of the lymphocyte. But not only do markers appear, but the lymphocyte starts, the activated lymphocyte begins to divide and forms many, many different kinds of lymphocytes, like natural killer cells, the NK cells, like lymphokine-activated killer cells, like B cells down here. And the B cells make the antibodies that help fight infections again. And T cells, most notably, the CD811B or suppressor cells. Now, what's unique about this particular situation is that the natural killer cells are neither mature nor do they work effectively to kill off. They're supposed to go back and find a cell that's affected or infected and destroy that cell. I think Nancy discussed that a little bit earlier today. And in order for the system to shut down, the suppressor cell is supposed to come back here and turn off IL-1 and IL-2. The problem with chronic fatigue syndrome is that we don't make NK cells that are mature and active, and so you can't kill off the invader. That allows for perpetuation. And the cytokines, like interleukin-1, interferon, TNF-alpha, interleukin-2, these are chemicals that make people feel sick. They actually cause fever, sore throat, swollen glands, depression, achiness, all of the symptoms that we see in this illness. Activated lymphocytes also make a chemical called glutamate. I want you to tuck that in the back of your head, no pun intended, because glutamate actually affects the central nervous system and is a key player here, but we're going to come to that in a minute. So this is how the immune system is involved. Now, this is a bit of a confusogram. It's very complicated, and so I'm going to take away part of it here and try and explain it to you. When a virus or a retroviral fragment or an interspersed element tries to attach to a cell membrane, let me restart. Let me say that over again. I'm going to use an example of a virus. A virus, when it gets to a cell membrane, tries to attach to the cell membrane, like an octopus, if you will, and then injects its genome into the cell membrane, and that's how it infects a cell. When interferon is present, and we learned about interferon a moment ago being made by the lymphocytes, the interferon can block that process from happening. But interferon also stimulates 2 or 3 antiviral systems. So now we're talking about the antiviral systems involved in the body. And one of the antiviral systems is the so-called 2,5 oligoadenyl synthetase, or OAS system. 2,5-OAS is then activated right here. And then that activated 2,5-OAS activates ribonuclease to make a chemical called active RNase L. And RNase L has the ability, it's an enzyme, it has the ability to break, to cleave, if you will, RNA molecules. So if an RNA virus gets into the cell, it can cleave that virus and destroy that virus. Unfortunately, the system tends to be shut in an on state in chronic fatigue syndrome. And it not only can destroy RNA virus, but it can also affect messenger RNA and cellular metabolism because it's stuck in an on state. So mostly active RNase L is a molecule that's about 80 kilodaltons long. That's not important, except to say that in chronic fatigue syndrome, we see a phenomenon that we don't see most anywhere else, except perhaps in MS, and that is that 2 enzymes, calpain and elastase, are able to break that 80 molecule. So you think of 80 little balls, okay? And those little string of balls can be broken by calpain or elastase into a 37-ball element and fragments that are referred to as ankyrin fragments. I know it's hard. Bear with me. The ankyrin fragments are able to stimulate a part of the body. They actually combine with something called ABC transporters or ATP transporters, and they cause a problem that is referred to as channelopathy. And so what I'd like to do is point out how very, very important the channelopathy can be in this particular illness. This is a summary of several of the effects that channelopathies can have on the human body, and mostly because a channelopathy leads to an influx of cellular calcium into cells, and it allows for potassium to come out. You know, the cell is like a little balloon, and that little balloon is constantly being filled up with nutrients, and the pumps that do that are constantly pumping calcium in, or calcium out rather, and potassium in. And so if they're affected, then the balloons don't do like the balloons are supposed to do. And the result is very low body potassiums, which is well documented in our patients. It can affect irritable bowel and cause an overactive bladder. The overactive bladder due to decreased ADH, or antidiuretic hormone. We see low blood volume, low blood pressure. Because kallikrein and bradykinin are stimulated, we see bronchial reactivity. So many patients have just a very, very mild asthma that can be picked up on sensitive pulmonary function testing. The intracellular pH drops because of the calcium and potassium changes. Prostaglandins, as we see, are manufactured. And prostaglandins are chemicals that are very inflammatory. There can be sodium retention, which can explain a lot of the swelling. So many of you I know experience that vague swelling of all over puffiness, sometimes not obvious to others around you, but certainly obvious to the victim. And an increase in sympathetic tone, so you're always feeling hyper, nervous, maybe difficulty falling asleep, thoughts that won't turn off because the sympathetic tone is increased. Low magnesium, neuromuscular problems are linked together, vasoconstriction, GI loss causes diarrhea that's so common in our patients, and secondary metabolic alkalosis, and hyperventilation as well. So I think you can see that the channelopathy explains many of the symptoms that we see in chronic fatigue syndrome. Going back to the confusogram again, let's look at the other side of the equation here. Again, interferon attaches to the cell membrane and stimulates another antiviral mechanism called the PK antiviral system, or the protein kinase antiviral system. Again, activated 2,5-OAS activates PK to PKR, and two things happen. Most notably, PKR causes cell death or apoptosis. And many clinicians have noticed that when patients are doing less well, that the white blood cell count will drop, probably due to apoptosis or cell death from PKR, or at least possibly explained by that. Another effect of the PKR is that it stimulates nuclear factor kappa B. So let me turn to this new system here, the nuclear factor kappa B system. And as you can see from the top, PKR is probably the major reason that this system gets inducted, but NFKB can also be stimulated by stress. It can be stimulated by ultraviolet light, and by bacterial infections or viral infections as well. Now, NFKB does two things that contribute to chronic fatigue syndrome. The first is that it induces an enzyme called cyclooxygenase 2, or COX-2. And COX-2 goes down a cascade and forms more prostanoids, which are things like prostaglandin, prostacyclin, and thromboxane. Again, these are very inflammatory compounds and could explain some of the inflammatory type symptoms that we see. You all are intuitively familiar with COX-2 pathway because many of you have taken Celebrex or have taken Vioxx, which are COX-2 inhibitors. These are anti-inflammatory drugs that are designed to block this particular pathway and cut down inflammation. Okay? The other thing is that NF-κB stimulates what we call nitric oxide synthetase, or inducible NOS. And before I get into that little complicated scheme, I'm going to divert for just a second and talk about cellular metabolism. If we could take a cell out of your body and look at it under the microscope, you would see that all of the cells in your body, except for the red blood cells, have a little energy factory in there called a mitochondria. The mitochondria, it manufactures the energy in the cell by taking NADH from routine metabolism. This comes from the Krebs cycle or the citric acid cycle. And so cholesterol and fat are transformed by the Krebs cycle or the citric acid cycle into NADH, which is then reduced to ATP, which is a form of energy. It's a chemical that gives energy to the cell. And another molecule of superoxide. And it's the superoxide that's very important, because superoxide is an extremely toxic oxidizing agent. It's normally confined to the mitochondria. But if the mitochondria is defective, a weak cell membrane, a dying cell, then superoxide can get out, and that's where some problems can obtain from. Normally, the superoxide is contained within this mitochondria, as you see here, and a very ubiquitous enzyme called superoxide dismutase, or SOD, which you can buy at the health food store, a very ubiquitous enzyme called SOD reduces that to peroxide. And then in the presence of glutathione peroxidase, the superoxide is reduced to water, which of course is virtually harmless. So that's how we get rid of a very toxic agent, by converting it mostly to peroxide and to water. Only if the mitochondria is defective, or only if SOD is deficient, do you have a problem with superoxide. So with that said, let me move on to the last step in this complicated process, and that is what Martin Pall has referred to as the nitric oxide peroxynitrate cycle. Nitric oxide, peroxynitrate, those are the chemical formulas, or more familiarly referred to as the no-oh-no cycle. Okay? Now, nitric oxide is no more reactive of an oxygen species as is oxygen itself. It's not really dangerous to have, and it's a natural byproduct of metabolism and oxidation. Carbon monoxide can stimulate it, pesticides can stimulate it, but in small amounts it's good. I mean, we use nitroglycerin to stimulate nitric oxide in the bloodstream so that you can vasodilate arterioles and arteries and treat heart disease, and we use it to control pain. So small amounts are good. But when nitric oxide builds up in high quantities, it competes with SOD, and it allows this superoxide to take over. Now here's the problem. Here's the problem. Nitric oxide, when it combines with superoxide, forms peroxynitrate, as you can see from the equation up there. And it's the peroxynitrate that is an extremely potent oxidizing agent. And as you can read down at the bottom of the page there are a number of very serious problems that occur when peroxynitrate builds up in the system. There is a rate-limiting step, however. You have to understand that you can get no more peroxynitrate than you have of the superoxide. One molecule superoxide makes one molecule peroxynitrate. So if you can control the superoxide, you're in good shape. But peroxynitrate, or oh-no, can reduce ATP, which is the energy source of the cell. It reduces glutathione and the polyunsaturated fatty acids that are so important for cell membranes and for mitochondrial membranes. It essentially rusts protein and lipids and neuron walls and cell walls. It affects mitochondrial and ribosomal membranes. It affects DNA membranes. It can get into the blood-brain barrier. It can get into the brain and cause direct effects there. It blocks the cytochrome P450 system, which is the major detoxification system of the liver. And so when peroxynitrate is present, then patients find it difficult to handle, to metabolize drugs. It suppresses natural killer cells, which may explain some of the first part that we were seeing, and it suppresses corticotropin-releasing hormone, which is thought to be the cause of the suppressed HPA axis. So what I'm trying to do is show you these different areas, the immune, the metabolic, the infectious areas, and how they all affect different systems in the body. Now there's just one more little step here, and we're all done and can put it all together again. And this next step is that nitric oxide synthetase, which stimulates nitric oxide, not only comes from the NFKB system, but to a smaller extent, a very much smaller extent, it can come directly from the brain, where it's called NNOS, or from the heart, where it's called endothelial, or ENOS. And so that's another source of it. But more importantly, there's a direct effect on the central nervous system here. Carbon monoxide, organophosphates like the pesticides, solvents like toluene, benzene, the VOCs, the volatile organic compounds that are so commonly seen in carpeting and new house products. The isocyanates, that's the new car smell. When you get a new car, that's isocyanates that you're smelling. Formaldehyde. All of these things can be absorbed directly into the brain through the nasal cavity, through the olfactic nerve, and they affect some excitatory receptors that are referred to as NMDA receptors. Okay? NMDA receptors can also be stimulated by glutamate. And if you'll remember, when we first started talking about this, I pointed out that in the immune system, activated lymphocytes make glutamate. So that's one of the sources of glutamate. Glutamate also comes if there is damage to neurons, decreased blood flow in the brain. It's a protective mechanism inside the brain. But it stimulates NMDA receptors, and the NMDA receptors are what cause anxiety, panic, and sleep disturbance, particularly the increase in the sympathetic nervous system. I might explain it another way, that there are basically two receptors that control how hyper or how calm an individual can be. NMDA receptors are usually balanced by GABA receptors. NMDA receptors are excitatory. They make you hyper. And so if these are stimulated a little bit, you get a little bit hyper, a little bit jumpy, a little bit tremulous, a little bit nervous. If it's too much, you can have a seizure. On the other hand, if GABA is increased, it makes you sleepy. If GABA is increased too much, you go into a coma. And in the body, these are normally balanced. So by having these kind of effects on the central nervous system, you're unraveling the balance, so to speak. Okay? So that's it, Cindy. I've tried to do my best and put this whole thing together. And I came to one conclusion. And that is, there is no unifying concept or theory for chronic fatigue syndrome. The unifying theory for chronic fatigue syndrome is that there are a bunch of systems that are acting together and in concert, and one acting on the other, that work to cause many, or can at least explain many of the symptoms that we see in chronic fatigue syndrome. And I think that probably chronic fatigue syndrome is a multifactorial illness. I think most of us in this study would probably say the same thing. It's a little bit like cancer is multifactorial. You know, cancer can be stimulated by estrogen in breast cancer, for example, or by coal products can stimulate bladder cancer and kidney cancer. And we know, for example, that a virus, the HPV, the human papillomavirus, can stimulate cervical cancer. Okay, so cancer, although we think of it as one term, one problem, it can be caused by a number of different factors. And I think chronic fatigue syndrome is the same way. There may not be one factor that's involved here, but multiple that are involved that throw off these varying systems. So the multiple theories must combine. So now, the reason that I wanted to share with you, even though it's complicated, but the reason that I wanted to share with you the biophysiological approach is that it addresses so many of the puzzles that we see. Why are so many systems involved? I think we made that clear. Why does CFS persist? It's because these symptoms persist. They don't have the turn-off mechanisms that they're supposed to. Why are there multiple triggers? Because there are multiple factors that can trigger these different systems. Why is there no single trigger? Why is there no hit and run that we can find? Because it's not just one thing, it's many, many things. The symptoms are variable because people respond in different ways. This particular theory explains the fatigue, it explains the post-exertional malaise, it explains a lot of the overlap syndromes that we see, it explains why chronic fatigue syndrome is exacerbated by stress. Why are people so stress sensitive? Because it affects these chemical systems. How can you have 3 major epidemics and it not be infectious? Because it could be a radiation, it could be something toxic, it could be any of those other factors that we talked about. And why do things like supplements and vitamins and antibiotics help? And I think you understand why now, because those various supplements and vitamins and antibiotics affect various parts of the system. So in your handout, I think you'll find a multicolored sheet here, and I'm not going to ask you to go through that. But what I have done is tried to summarize all of this talk for you so that you can sort of go through it. And I'm going to see actually if I can pull that up. Well, here it is. Okay, that's basically what you're looking at on your screen. And what I've tried to do in the blue bar at the top is point out the various things that can trigger these systems. In the orange rounded boxes, these are the various systems that can be involved. Below you see the basic metabolic pathways that are involved. And in the pink are the various symptoms that are triggered by these systems when they're involved. I think what you all really are most interested in knowing is the part that I don't have time to go through right now, unfortunately, and that is the therapeutic approach. And so I've put that in green at the bottom. And I think you can see that if you're going to deal with the immune system, it's important to take away the triggers. It's important to treat the infections and support with B12 and glutathione. If the RNA cell system is involved, we have some experimental drugs that are being studied to control that, and certainly antiviral drugs may be effective. We've talked about the COX-2 inhibitors, that they might be fruitful in some cases. And under metabolism, you can see there are a number of supplementary items. These are not cures. They're not specific treatments. But if by laboratory studies you can identify abnormalities in these systems, they certainly can be addressed. And then lastly, by using NMDA receptor blockers or by building GABA, we can restore the balance of NMDA and GABA in the nervous system and help that way. So I hope you've gained something from this. I hope I haven't overwhelmed you so late in the evening. And I thank you very, very much for allowing me to give you this presentation this afternoon.